السلام عليكم. Today, inshallah, we will start with our journey and complete the journey for medication safety with medication error. This is the topic. It's a very important topic. We will start with medication error, root cause analysis, and the Sentinel event. Let's start our first session with medication error. As we know before, medication error is the one of essential safety requirements with the laser, lookalike sound alike, and also high alert medication and hazardous medication and chemicals. By the end of this lecture, every participant will know what is medication error, classification and categories, causes of errors for medication, how can we decrease the medication error, and medication review and reconciliation. Let us start with the definition of medication error. What is medication error? For point of view, this is any preventable event that may cause or lead to inappropriate medication use or patient harm while the medication is in control of the healthcare professional. Before we go in deep in our topic today for medication error, we will know some definitions, which they are near miss. What is near miss? Near miss is any variation in the process lead to undesirable outcome. What does this mean? This means the medication until to reach to the patient, they will have a lot of process, such as ordering, dispensing, maybe transcribing, and also administration and evaluation. So there are many processes until reaching the patient. Maybe there are any variation in one of this process and lead to undesirable outcome. But the medication will reach to the patient in safe. So in a simple definition, this is mean any error happened but not reached to the patient. But actual error, it means a mistake in prescribing, dispensing, or planned medication administration that occurred. This error reached to the patient and may cause patient harm, require further monitoring, require hospitalization or extension of hospital stay, and may affect, cause life-threatening situation, or may cause death. This is the classification of medication error, and maybe in ordering, in transcribing, prescribing, dispensing, and administration. Maybe they are in wrong medication, wrong dose, wrong frequency, wrong timing, wrong patient, wrong administration route, a lot of categories, a lot of classification of medication error. And we already make categorization for medication error and the near miss also, and the Sentinel event that we will talk later. But for medication error, this is circumstance or events with a capacity to cause error. What is this meaning? This means this error not reached to the patient. It means this is near miss. Also, error occurred but not reached to the patient. This is also a near miss. But from this category that I will say now, and the last category, this is called actual error. This is error already happened and didn't cause harm, but the error already reached to the patient. Like extra dose from Panadol, this is received by patient. This is error and happened, but not cause harm. Error reached to the patient and require monitoring. Also, Error reach to the patient and result in temporary harm and require intervention. Error reach to the patient and result in temporary harm or initial or prolonged hospitalization. Error reach to the patient and result in permanent harm. We see that this is all categories increase in severity of harm. And another category, this is error reach to the patient and require intervention necessary to sustain life. The last one is and error reach to the patient and contribute to patient death. This is more one in severity, and after that we need to make RCA. What is the meaning of RCA? This is root cause analysis. We will discuss this later and we will explain this is in this lecture today. But we will note what is or what are the reasons of medication error. There are a lot of reasons will cause a lot of medication error. This is factors associated with healthcare, maybe in communication with doctors or healthcare workers. Also, there are factors associated with patient. Maybe they are not conscious. There is an old patient and there is no history about this patient. Factor associated with work. This is heavy work for all the staff of healthcare categories. There is no policy and procedures. Also, there are a lot of factors associated with computerized information system. Maybe the new system, this is all of healthcare, this is facing a lot of problems to deal with the new system. There is no one to deal with the new system. They're not taking a lot of orientation about the new system. All these factors affecting all medication error. Also, factors associated with medicine. Which one? This is LASA medication, high alert medication. There are a lot of precautions that we already talked yesterday in day 2 for medication safety about some common risk factors of high alert medication and common risk factors of LASA medication and how to decrease the errors resulting from high alert medication and how to decrease the errors resulting from LASA medication. And there may be errors in ordering when the doctor started to order the medication. Maybe there is a lot of errors in the ordering and it's not completing by eligible handwriting. This is mistake in the dose, right in route, rate of infusion, and so on. Labeling and packaging and transcribing, maybe a lot of wrong transcribing in the medication name and also in the patient name. A lot of factors related to medicine that cause a lot of medication error or near miss. So now we can ask us about how can we prevent medication error. We must put a safeguards. One of these safeguards is Swiss cheese models. What is this Swiss cheese models? This is a lot of barriers we must put when start to prescribe the medication until reaching to the patient. Starting in prescribing for doctors like CPOE. This is the best way to prescribe the medication. And after that, from the transcribing, if there is transcribing in the healthcare organization, must be double check in the order, appropriateness from the pharmacist. All this we will discuss later. But what is a sausage cheese model? This is a model put by one professor. He said that this is holes in like cheese, and when there is a lot of factors of error already meet each together, the errors will reach to the patient. This is in brief because this is lead to one lecture to discuss this sales cheese models. Stages of medication management to start to prevent the or decrease the errors of medication error. As we know before, we said that medication error management starting from storage, procurement, and dispensing, prescribing, dispensing, administration, and monitoring and evaluation. So we must try to put barriers in every stage to decrease the medication error. So let us start from the storage. How can we decrease the medication error during the stage of storage? One, this is a barcode. We can use a barcode system to segregate a high alert medication and less medication during the storage this and follow the policy and procedures when we deal with the high alert medication and the less medication, using a label and alerts when appropriate. Ensure a label when we already make storage for bottles face forward, not backward. This is in the stage of storage. When the patient admitted in the hospital must make medication reconciliation, as we already talked yesterday in the day 2 in medication safety, as this is very important to take the history from the patient before admission and make a list of the medication that he already received before and put best possible medication history that he already received before admitting in the hospital, and upon this list we already make the plan that he already will follow in the hospital. After that, ordering and review the history of the patient and completing the order for appropriateness. So how can we make appropriateness? This is the role of pharmacist during transcribing, and we will know the role of pharmacist may be and checking the dose, frequency, drug interaction, food interaction, any contraindicated related to the patient, and be sure from the dose of frequency and everything related to the medication, and be completing the doctor order. And the best way for prescribing the medication is CPOE. What is CPOE? This is a computerized physician order entry. Transcribing, this is a way, but this for reviewing the medication before dispensing by pharmacist to make transcribing for the order of medication that already written by a doctor, but this is lead to a lot of errors that result from wrong transcribing, maybe wrong transcribing for the medication, wrong transcribing for the patient. So this is the way lead to a lot of errors. So better to decrease the stage of transcribing. And the best way to make CPOE and the doctor who be responsible for entering the medication. Reviewing for a medication. This is the review we will by appropriateness by pharmacist and by nurse. The review for appropriateness by pharmacist, this is we will talk in details with Dr. Iman in session 2, but I will give you in brief only, and this is the double rule for appropriateness by pharmacist and by nurse. By pharmacist will be before administration, before dispensing, and by nurse before administration. By pharmacist, they have role in checking the order, those with drug with names, with frequency, with drug interaction, with drug food interaction, with allergy, and also any contraindicated related to the patient before dispensing. After dispensing and the double check for the pharmacist, before giving the medication for the nurse will administer the medication for the patient, but make appropriateness for the medication. The role of nursing may be 7 or 10 rights, but the last thing is 10 rights. What is 10 rights for the nursing? Right patient, right dose, right frequency, right medication, right to refuse, right documentation. This is all the role of nursing must be done before administration for medication to the patient. All these ways lead to decrease the error that be from medication error. After that, the preparation, pharmacy or admixture should be under suitable condition to facilitate for pharmacists to prepare every medication, and the double check policy must be followed during receiving prepared medication from in the outpatient. Licensed pharmacist must make double check for prepared medication, and unit dose must be followed. This is a good system for dispensing medication in the inpatient. For administration, CPOE and barcoding system is a good way for administration medication for the patient. Documentation, this is must be documented in the medication in the file for the patient that he received every medication after receiving it. But this is by CPOE. This is the first way to and the first way to decrease the error that result to or result from medication. Double check. Double check. This is the main or main key in all process to decrease medication. How can we make monitoring and evaluation to decrease in medication error? Reporting. When you face already any medication error, you must be reporting. We will know later. So we know now what is the rule we already make reporting for medication error. This is occurrence variance report, OVR. This is our internal form. This is different. The form will different from healthcare organizations used to document the details of incident and used to investigate the occurrence, what happened, and used for making correction for the action taken. Let us know what is the type of errors, errors or potential errors in healthcare. First, at risk behavior, near miss, adverse event, and sentinel event. What is the meaning of at risk behavior? Anyone knows about anything about at risk behavior? Look at the second picture. You see the man already standing up on this wall. If there is no process variation, but there is a probability of error, yeah, this means when you already look at this picture and you see this man, this is in there is a risk to this man will be fall down.
Sorry
But
for this corruption, but doctor, your screen not sharing.
thank you for you, but I will make a screen. Thank you.
Okay.
Still screen not sharing?
Yes.
Okay, 1 second. It's okay now?
Yes, this is good.
Thank you. I think here we already stop sharing from at risk behavior. At risk behavior is a type of error or potential error. Look at the scene, look at the picture with me, and see this picture. See this man. This is already staying up on this wall. This is a risk to be fall down from this wall, from this one, and may risk and reach to him. But if there is no variation in the process, but there is a probability of error. What is this? This is called at-risk behavior. So, at-risk behavior is any consciously or non-consciously controlled behavior with a perceived uncertainty about its outcome. So, the risk or error may reach to him or not. So I will give you example for at-risk behavior. This is writing the order of medication in the medical record in a noisy environment. So the error may happen or not. Taking a shortcut with the patient. Also, this is the error may happen or not. This is at-risk behavior. As we know, as we said before, near miss, any process in variation but didn't affect our outcome. For which recurrence carries a significant chance of a serious adverse outcome. For example, wrong medication prescribed for the patient. Doctor write wrong prescribing. Doctor write a medication for the patient, and this is not according to his diagnosis. Wrong site marketing. But this is near miss, but not related to the medication. This is near miss in general. So now we will know a lot of information about root cause analysis. After medication error happened, and you make already report for medication error happened, we will make analyze for this category of medication error. This is now this medication error reached to the patient, and we will make root cause analysis to know and to solve this problem. What we will know about RCA? By learning objective, by the end of this lecture of RCA, we will know what RCA, what root cause analysis, why we make RCA, when we will make root cause analysis, how can we make root cause analysis, and who will make root cause analysis. First, what RCA or what root cause analysis? See this picture. This is a tree. This root of this tree is root cause analysis of the problem. Root cause of the problem. Down, deep, we didn't see it. And up, this is all surface of the symptoms of the problem. So when we solve this, that appear for us of the problem, after that, all these roots of the problem will grow again and the problem will repeat it again. So RCA or root cause analysis will help us to solve this problem from the root cause. So what is root cause analysis? Root cause analysis is a method of a problem solving used for identifying the root cause of the fault or the problems. It is widely used in this to solve this problem or solve the medication, the errors that already happened. Root cause analysis is used often in a proactive management. And this is better to use in a proactive management. Why? To identify the root cause of problem. This is a factor that was in main cause of the problem. It is customary to refer the root cause in singular form, but one or several factors may in effect consist two root causes of the problem under study. Root cause analysis is useful for process for understanding and solving the problem. Figure out what negative events are occurring. Look, look at the complex system around this problem. Identify key point of the failure. Determine solution to the address of these key points of root. This is in brief or shortly the steps of root cause. I will explain this one in details. But how can we make it, or how can we conduct a root cause analysis? First, we will define the problem. We must know or ensure what is the problem that we face. Ensure you identify the problem and align with a customer need if we make it for a proactive. If not exactly or anticipate the problem from a customer perspective, what are the specific issue you observe? What happened if you don't tackle the problem now? What is in business impact? Second, collecting data. Collecting data about what? About what customer need if we already making a proactive, but when we already making it to solving a problem, we must make or define what is your problem you're facing already and collecting all data starting from what is the procedure starting or happen from upon admission of the patient to upon admission of the patient until receiving error or happened the error. So collecting data from several or many ways like database, questionnaire, interviews, surveys, a lot of things. See for this picture, this is the stages of how can we make root cause analysis. Define the problem, collecting the data, identify possible causal factors. So then identify root causes. After that, recommend and implement a solution. This is the tools can use or help in root cause analysis. A lot of tools can be used in solving the problems that facing in and or helping root cause analysis to solve the problem. But these tools lead a lot of sessions to understand it. Pareto chart is called 80-20. How can we make 80-20? 80-20 to know what is the problem you have already, and we make priority to know what is the 20 of causal factors affect in solving 80% of your problems and give it prioritization to solve your problem. 5 why to analysis. This is not 5 why now, but this is you ask yourself about why this problem happened, why and why and why until you find the answer for your problem and determine the cause of your problem to find the solution. Fishbone or cause-effect diagram or Ishikawa diagram. This is in your picture. This is the diagram for Ishikawa or cause factor diagram or fishbone. This is must be like this. At the head of the fish, we write the effect or the problem if you solve or if you make it for a proactive. And this is all you see. This is arrow. This is we write the causes that already lead to or affect the problem. And when you already solve this one, we already reach to the solution or reach to the effective that we need. After we making fishbone, we already make flow chart. What is the flow chart? You see here two picture, the right one and the left one. See, the left one is the high level. What is the meaning of high level? When I already said for you, I will talk with you about high level. This means this is not a high level in talking. No, this means high level in flow chart. It means I will give you only just title for them or headline about the process or headline about what happened when the patient come to the hospital or title about the flow chart. This is means high level of flow chart. And this is must be on this same way. The right one, this is details flow chart. So the left one, this is high level of flow chart. It means when the patient come from ER, he will go for admission office, and after that he go for reception to take admission the patient to come to the hospital and go for reception to take a ticket, and after that go for doctor. After doctor informed him to go for inpatient unit, he will go for nursing station, and after that admitted. This is headlines for what already patient do in the hospital in headlines. But the other one, this is details flow chart. This is consists of every step in the process to discover what is effect on the patient in the process, and we will take what happened already in the every process, every steps, to know what is the solution for the problem and what effect on the outcome that we have. After that, we can make failure mode and effective analysis. This is also the way to help in root cause analysis, and this is already confirmed of and this already failure mode and effective analysis. This is the one of proactive to improve our problem, to solve the problem that we already facing. Look at this picture. This is the example for medication error happened already to the patient, and this is the RCA done already for patient. This patient already come to the hospital, and the organization and the healthcare organization admitted with DKA. What is the meaning of DKA? This is diabetic ketoacidosis, but this patient already moderate, and the doctor write for him regular insulin, and he received, but unfortunately he already received already insulin, but this is not regular insulin. This he already received he already received the hemoline mixed start insulin, and also received this medication by infusion. After that, the doctor already noticed that this is in brief and for this problem. After that, the doctor already knows this patient already by the investigation, this patient already confirmed to a severe DKA by investigation of him. and this is lead to severe hospital, increase in length of stay of hospital to 28 hours. This is for this patient. What happened and what is we already done for root cause analysis? The At the head of the fresh, the wrong medication administration lead to severe DKA, and this is increasing the length of stay of the patient. And you see, this is all cause factors that is already affect on the patient. This RCA here not already proactive. This is to solving the problem and to know what is the cause of problems to solve this problem and to put plan to prevent this error to repeat again. There are a lot of problems that happened, and this is from a lot of categories already affect the process that happened already, and we try to discover this problem by collecting the data and define the problem and define a problem, and after that making a fishbone and making a deep RCA to investigate and collecting all data and try to solve this one. After that we already improve process and prevent this error, and from the solution we giving a lot of orientation and giving and prevent errors to decrease this medication error to repeat again. Now, after this RCA, when the medication error category or severity reach to the patient and lead to physiological injury or death or harm, severe harm, may be serious physical or psychological injury, this is called sentinel event. So let us start with a sentinel event journey. I will give you some in brief in sentinel event. Sentinel event, it is unanticipated event in the healthcare setting resulting in death or serious physical or psychological injury to a patients not related to the natural course of patient's illness. Before we said that the error type or potential type, we said that at-risk behavior, near-miss, adverse event, and sentinel event. So, what is the differences between sentinel event and adverse event? Adverse event is this unanticipated, undesirable, or potential dangerous occurrence in a healthcare organization. This is incident involved this serious or physical or psychological injury. This is called sentinel event. Example for sentinel event. Look at these two pictures. The first one is the patient have operation, must be in the right hand, and this is already in left hand. The second one, unintended retention of a foreign object in a patient after an invasive procedures, including surgery. This is a sentinel event. Also, unanticipated death of a full-term inpatient, discharge of an infant to a wrong family, abduction of any patient receiving care or treatment and service. This wrong eye, this patient already admitted in the hospital to make operation in the right eye, and this patient already received operation in the left eye. This is catastrophe. So it's called never event or sentinel event. DCI reported from 1995 until 2008. This is the report and the study of reported already in Joint Commission International. This is the wrong side surgery documented by Joint Commission International that already increasing in wrong side surgery. And said for us by JACO reported for 13-year period from this year, the 691 wrong side surgery and 470 major medication error resulting in death or permanent disability, 7 cases of endorsement of wrong baby, 119 incidents of wrong blood transfusion, wrong matching, 58 incidents of retained surgical items in the patient abdomen. This is the healthcare errors categories already that we already set for an medication error. Also, this is the health categories, same categories, but for healthcare, the at-risk behavior and near miss and adverse event. This is already like medication error, and the other one for a sentinel event. At-risk behavior, this is a circumstance or events that have capacity to cause an error. Near miss also for an error occurred but not reached to the patient. Category C until category F, the same like a medication error, this is adverse event. And from category G until category I, this is already sentinel event. Error or potential error in healthcare, as we already discussed before, at-risk behavior and near miss and or medication error or sentinel event, this is classification for them for error happened or error reached to the patient and harm. For at-risk behavior, this is probability and probability may error happened or not, as we already agreed. Error reached to the patient, no. Harmful, this is not harmful. Near miss could happen error or not, and the error reached to the patient, no. And harmful, no also. Adverse event, including adverse event and medication error, this is called adverse event. This error happened, yes, happened. Error reached to the patient, yes, reached to the patient. Harmful, could be harmful, could be, but we don't know. Sentinel event, error happened, yes, error happened. Error reached to the patient, yes. Harmful, major harmful. That I said for you as examples that I said before. This is the error, potential error in healthcare. Type of error, at-risk behavior, near miss, adverse event or medication error, and sentinel event. Reporting and aggregation analysis, RCA, and awareness. So at-risk behavior is awareness, yes. Near miss reported, yes, must be reported because at the latest standard in GCI and CBHIM, maybe near miss need to make RCA if this is very critical. Aggregation and analysis, yes, this is near miss need to aggregation and analysis. The RCA, if it might lead to sentinel event, must make RCA. Awareness, yes, awareness. Adverse event reporting must be reported. Aggregation and analysis, yes, must be. RCA, if reported already, must make RCA. Awareness, yes. Sentinel event must be reported. RCA must done RCA. Awareness, yes, must be awareness. What is the goal of the Joint Commission International Policy in the Sentinel event? Goals help hospitals to improve safety and learn from those Sentinel events. Help analysis of patient safety events for evaluation of corrective action and to reduce the risk and prevent patient harm. to protect the patient and improve the system and prevent further harm. I need to inform you something before we finish our lecture today. If you have any question and any discussion you need, I'm ready to answer for your question, and we will now we will have another session with Dr. Iman. She will discuss with you and explain the appropriateness of medication. This is now, but after we will take a rest for 5 or 10 minutes only. Thank you for your participation, and I hope I already rich with the knowledge for you. Thank you. Mm.
خلاص كده. بعدين السلام عليكم everyone. Good morning. في حاجة؟ السلام عليكم. Now it's a time for the second session for today about medication appropriateness. Medication appropriateness is really an important topic related to medication safety, related to accreditation, related to our daily work as a pharmacist, nurses, physician. Let's talk in details about appropriateness. By the end of this topic, you will be able to know what is the definition of medication appropriateness, to understand its benefits in medication safety, and to recognize how to do medication appropriateness review. First of all, we will have a glance about the history. This term appropriateness first introduced by Zermansky when he mentioned that it's a process where a health professional review the patient, the illness, and the drug treatment. The IOM, Institute for Healthcare Improvement, stated that every medication order should be reviewed by a pharmacist to ensure appropriate selection of drug, dose, route, and frequency, and to check for interaction with other medication. After that, the GCI, one of its main standards in medication management use, is the medication appropriateness. It's the medication prescriptions or order are reviewed for appropriateness. So this is simply when the appropriateness started to be discussed and mentioned in the healthcare organization. What is our goal for appropriateness? Simply, it's safety. Medication appropriateness review improves the quality and safety of adding a new medication to the patient treatment plan. And sure, it will reduce the risk of an adverse medication event. So let's talk in details about steps of appropriateness review. First of all, when we start appropriateness review, there is some steps should be known by all healthcare provider who will do appropriateness, or simply it could be done in a card. Then you can revise it each time with each new medication. The first thing that we have to be sure that this medication is appropriate. Is this medication right or not? Is this the appropriate drug? If it's appropriate, is this the appropriate dose, the appropriate frequency, appropriate route? What is the meaning of appropriate drug? Appropriate drug means right drug. So right drug means the right drug written in the sheet or in the electronic medical record is the same medication in hands of a nurse. Yes, this is during administration. But during review of the physician prescription, rule of pharmacist, during transcribing or before dispensing, we should know that why this medication written. So we need to know the indication of this medication. That's why the medication profile or the medical profile for the patient should be appear to pharmacist, whatever through the medical file or the electronic medical file. So first of all, we need to know if this drug is right or not, appropriate or not. So we should know first why this medication written. What is the indication for this medication? The second thing, we will check the dose. Is this the dose is right or not? Some medication have a common or usual dose used, but most of the medication have many dosing regimen according to the indication, according to the patient situation, according to the adjustment needed, according to the weight. So all of these details needed before we confirm this is a right dose for medication. Then the frequency. Frequency, dose, route, dilution, all of this details is under the term dosing regimen. Okay, frequency, then the route of administration. So we will check the indication for use. After that, we will check if there is any therapeutic duplication. This means that this medication, for example, enoxaparin and heparin, written in the same medication, so they are both anticoagulant. Is this right to be written at the same time or not? Maybe we can see some of two medication like clopidogrel and aspirin, both antiplatelet, written at the same time. Is this indicated or not? Is this meant by physician or not? What is the indication? Or it should be not written for this patient, like for enoxaparin and the heparin, it could not be prescribed at all together. After that, we will check if there is any real or potential allergies or sensitivity. As we talked yesterday for the EDR and the allergy, it's many steps. And actually, it should be the first step discussed with patient by all healthcare providers. The first step with the physician during reconciliation, the first step with the nurses before administration, the first step by the pharmacist during counseling, during education, during before dispensing. We should check by direct communication with the patient or patient family and by checking the patient file. And that's why the documentation of any allergy should be on a patient file, on electronic or on the medical file. Right. Why we mentioned real or potential? Because some types of allergy, it's mild allergy. So maybe the patient needs this medication, so we cannot prevent the patient from taking this medication. Maybe it's critical for him to take it. So that's why the allergy should be documented, the degree of allergy, and any details should, like the type of allergy appear, if it's, and what is the antidote given at the time. That's why. So we concentrated or we focus on real or potential allergy. After that, the real or potential interaction between the medication and other medication or food, which we call it drug-drug interaction and drug-food interaction. If we open the drug interaction checker, we will find a degree for drug interaction. For example, there is A, B, C, D, E, and X. So the degree of interaction is very important because some medication we can still, it could be still given to the patient and there is notes of the drug interaction. The recommended action for this drug-drug interaction is important. Some medication, no action, no need, some drug-drug interaction, no action could be taken. Others, a monitor should be done, but we still give those medication to the patient. Other is category X. It's completely contraindicated to give both medication at the same time to this patient, and a severe harm will happen. That's why a potential interaction is a very important. For example, you cannot go to a physician and tell him that there is interaction between these two medication and the action recommended is nothing to do. And if there is any monitor thing should be done, so you can simply ask the physician, for example, to monitor platelets, to monitor the ECG by QT prolongation, for example, or whatever the liver function. patient situation. Then variation from hospital criteria for use, and this is important issue that may be not known by some pharmacists. Every hospital or healthcare organization, there is a policy for using medication. Um, if this is a policy for one medication to be used for a certain indication, so if the indication for the medication different from hospital criteria should not be dispensed, or at least to start the communication with physician. Let's have an example for details. We know that liraglutide have two different brands for the same material. One of them indicated for treatment of diabetes and the other for weight loss. So in some organization, there is a hospital criteria for use of liraglutide because it's covered by insurance company, may be dispensed for free for patient. So it's also related to the issue of money issue. Some hospitals specify a criteria for liraglutide only to be prescribed for treatment of diabetes. So if the physician wrote it as for losing of weight for the patient, so it should not be dispensed by pharmacist, or he should communicate it with physician first. Another thing which is commonly used for off-label use of some medication. Some medication used for certain indication approved for FDA, and there is off-label indication. It's prescribed for a different indication which is not approved, which we call is off-label. So the pharmacist should verify why this medication written, and if it's written for off-label indication, we should communicate it for physician, because many things and many steps should be done after that. Like, for example, the dosing regimen may be different from what's from the common or usual dosing. Another thing, which is patient weight, a very important and critical information should be done, since patient admission should be clearly written. It's like age, should be specified and written clearly and also updated. Weight is a different, is a physiological parameter or a measurement that it's different maybe from each admission. So it should be updated. Many medication need dose adjustment related to weight, like enoxaparin, and it's important in case of pediatric patient also. Last thing, which is other contraindication. The medication may be appropriate for dose, frequency, indication, drug-drug interaction, patient weight, but there is contraindication for use, like patient with renal impairment or liver impairment or whatever the contraindication. So it should be revised that no contraindication for this indication. So this is simply the steps for appropriateness review. This should be done by clinical pharmacist or pharmacist for every medication added newly to the patient medication profile. Now, who should do this appropriateness? Ideally, it should be done by a clinical pharmacist. But because we know that no clinical pharmacist available 24-hour, no clinical pharmacist available in all stations, this mostly in all hospitals. So the clinical pharmacists were doing training, and there is a designated trained individual for appropriateness should be done. So all this healthcare provider can do the appropriateness. What is regarding the off shifts? That no available clinical pharmacist or in case of some emergency situation. So there is a 4 critical elements should be done at least for appropriateness review. That's why nurses also should be trained for appropriateness because they have to do it before administration. Allergy, lethal drug-drug interaction, significant or lethal, weight-based dosing, potential organ toxicity. This is 4 critical elements should be done each time, at least. This is the minimum appropriateness review should be done by all healthcare providers. Now, let's talk about the important role should be done by clinical pharmacist or pharmacist for appropriateness review. Now we know the steps that should be done with each medication added to patient profile. What is the rule? At least this is some rule, not all. If there is any potential adverse drug reaction, should be identified, detected, monitored, and documented. If there is any legal requirement, should be monitored also and clarified, like in case of narcotic medications or controlled. They should identifying any changes in dose, frequency, formulation, and route of administration to regular medication. For example, if the patient taking oral medication, this and another patient, there is a nasogastric tube, so this medication should be like grinding or mixing before administration. If there is any TBN medications, so all of this will make differences in formulation or for dosing, providing clarification for any dose changes, providing reconstitution direction for nurses and administration guideline. That's why from the standard should be IV protocol or manual putting in the all stations. Monitoring the patient response in case of therapeutic drug monitoring for some specified medication, which is what we call it narrow therapeutic index, like digoxin, amikacin. This medication, there is high chance of harm if there is any change in the dosing or concentration. That's why a therapeutic drug monitoring is an important service should be available in lab of hospital. Education, especially for new medication, which is not well known by all healthcare providers, and documenting the review. Any appropriateness review should be documented. Any intervention should be documented. For example, simply when we start a medication for a patient, or when the clinical pharmacist start to check the patient profile, we should know that no indication, there is an indication for each medication prescribed. And the second thing, there is all indication or in the patient medical problem, there is a medication to treat this problem. All drug should be appropriate. All dosing regimen should be appropriate. Should be right dose, right frequency, right route, right duration, right dilution, right rate, right dosage form. Also, we should check therapeutic duplication. We will check also if there is any medication duration ended, so this medication should be discontinued. We will also check if there is any indication or medical problem that no, like for example, patient diabetic and no diabetic medication prescribed. We should be confirmed that this patient, for example, blood sugar is suitable, or maybe this patient on diet diabetic, but only diet, no medication given to this patient. So if there is any medical problem need medication, we can recommend to start drug therapy. Sometimes there is a medication not available, or if available, but not in the dosing regimen suitable, not in the formulation suitable. So we will recommend alternative. If any dosing calculation needed, in case of calculation the weight for the patient, or we can adjust it according to renal parameter. We should calculate the creatinine clearance for the patient. If there is any hepatic dose adjustment needed, sometimes the dose or dosing regimen is correct, but we need to make optimization for the dose. Like we can increase this need to the details for the clinical situation of the patient. Like we can increase the dosing regimen to make it the maximum. So the first dosing regimen is right. It's a right dose, not wrong dose. But for me as a clinical pharmacy, and I monitor the clinical situation of the patient during clinical round, so I will recommend to make optimization for the dosing by increase the dose to the maximum dose. Another thing, also the pharmacist may can catch some medication that is not administered. We should check why this medication not administered. Maybe the patient refuse, and it's one of the rights for the patient, right, to refuse. Another thing may be missed by the nurse. Maybe the patient is will have an intervention, like it's have an operation, so the anticoagulant by order of the physician will be discontinued for 24 hours before administration. So we need, or we have to know why this medication not administered by the patient. Is this missed, or this a real indication to hold this medication? Some also indication order from physicians that NBO or nothing per oral for this patient, so the dose is hold. Maybe some contraindication, like there is a bleeding, or there is a decrease in platelets for anticoagulant, so the medication is held by physician. That's why there is some like order or instruction written after in the medication sheet after each medication should be checked by nurses before administration. For example, some patient on more than one antihypertensive medication. So the nurse will read the instruction. For example, this medication should not be given to this patient if the blood pressure is less than, for example, 120 over 70. So I will inform the physician and tell him that I will hold this dose because the patient blood pressure is less than the blood pressure specified in the medication sheet. The same in case of some beta blocker. The physician wrote that this medication should not be given if the heart rate is less than 60. So before giving, at the time of administration, before giving this medication, I will confirm that the heart rate is within the range specified by physician. So that's why the instruction written by physician is very important, and to revise this instruction each time before giving medication is a very critical. Another thing, that drug-drug interaction or drug-food interaction, also experiencing allergy or adverse drug reaction. This should be identified and monitored. Another intervention could be done, like suggestion to shift the patient from IV to oral when needed. And there is specification for this switching should be revised and checked before suggestion. Sometimes we make the escalation right in case of antibiotic patient in sepsis, empirical antibiotics given, then after, for example, few days after improvement or after culture result released. So we can suggest to de-escalate the antibiotic, to discontinue one or more of antibiotics, or to decrease the dose of antibiotic. Another intervention that to provide drug information. So that's some, not all, of the role of the clinical pharmacist or pharmacist intervention after reviewing the appropriateness of the medication sheet. Now let's discuss some of cases as an example so we can implement uh, what we discussed in appropriateness review. What you can see here, this is a medication written by physician. It's a trade name, Clexane. As we know, the generic name, it's enoxaparin. So just we can revise how to make appropriateness review for this medication. First of all, what is this medication? It's enoxaparin. We should know what is the indication for this patient. This enoxaparin is anticoagulant. Why it's written for this patient? Anticoagulant. Is this for DVT prophylaxis? Then we will check the dose. If there is any other indication like atrial fibrillation, then we will check the dose. Now the dose is 40 milligram. The route is subcutaneous. The frequency is every 24 hours. We will check the other complete information, the date, the time, the duration. We will check if there is any therapeutic duplication, if there is any drug-drug interaction, if there is any contraindication, for example, if there is a renal patient, or there is any thrombocytopenia, for example. Okay. Second medication, tigecelin, it's antibiotic. Okay. The dose written here is 50 milligram. So what is the dose of tigecelin? As we know, tigecelin is antibiotic, should be started by a loading dose. So we will check if the loading dose prescribed or not. If not prescribed, I will contact with physician that first we will start with 100 milligram once daily. Then we will start the maintenance dose 50 milligram twice daily. Okay. Another example, which is commonly used antibiotic, meropenem. Meropenem has a many dosing regimen. Okay, we will confirm that it's a right medication. There is indication. It's a carbapenem. Then we will confirm the dose. There is any renal dose adjustment needed. Okay. Okay, meropenem, we will check on dialysis or on CRRT, so it's a completely different regimen. One of the important medication, azithromycin, it's used as antibiotic and also as antiviral in case of COVID patient treatment. The important adverse drug event and also drug-drug interaction that to monitor the ECG. That's why QT prolongation is recommended if we use azithromycin in case of some elderly patient with cardiac problems, or when used with other medication which also prolong the QT. An example, nifedipine or Adalat long-acting. This is just an example that long-acting medication or sustained release medication should be administered as a whole tablet, should not be crushed. So this medication is not suitable to be grinding or mixing and giving through NGT. If given like this, it will be all the medication released, and the bioavailability will be increased at completely different than the formulation prepared for this. So it's an important issue, should be considered. And finally, why we make medication appropriateness? What is the benefit expected? Sure, it will reduce the adverse drug event, will decrease the length of stay, will decrease the probability of readmission, and decrease the medication cost. So please do your role in medication appropriateness. It's an important thing in medication safety. Your role should be revised for each medication on daily basis. Any thing different from the hospital criteria or your role, you should contact with the physician or pharmacist or nurses, whatever. I hope today's session is good for you. You can follow up what we discussed and implement in your daily work. This is the end of the session 2 of today. I want to thank Dr. Adina for their informative lecture about medication error, root cause analysis, and Sentinel event. And if you have any questions, please contact with us. Tomorrow, inshallah, we will have the last session about antibiotic stewardship program. Thank you for your participation, and thank you. Assalamu alaikum wa rahmatullah. طيب في مين اللي رفع ايده؟ طبعا. السلام عليكم. السلام عليكم. انا اللي رفع ايدي. We can see here one raised hand. Please, if anyone have a question. Nice.